A very good afternoon to all the people assembled here. Now we come to the second session, plenary session, endodontic failures and retreatment strategies, dilemma and decision making. I've been practicing for the last 32 years. I've been doing root canal for the last 32 years. I have done root canal with just my reamer and files when I was doing my MDS. And I defined success at that time because I see my patients after 30 years. But then now I have the most recent equipment. I have the Extaro 300, I have the rotary instruments, I have the laser. But still, I can define success. But what actually is success and failure in endodontics is something which is a question which is debatable for hours. Even now, as an endodontist practicing for 32 years, I can never say, I never tell any patient it is going to be 100% success. If in case there is a problem, there is another procedure which is possible that is called as retreatment. And if that fails, still we have other procedures to be done. This is exactly that I tell my patient. Because we never tell that if there is a patient gets fever, he will never get fever again. Or if he has a fractured arm, he will never get fractured again. So these are the things which is some questions in our mind. We all of us know that we all depend upon a radiograph, which is a two-dimensional picture. But we all very well know if we have to really analyze our endodontics, we need micro CT, which is less than 0.25 micrometer sections to define success, which none of us do in our practice. So here we are all together, the senior clinicians, academicians are here together to come to a consensus on how to define the success and when to go for retreatment. And I as a practitioner, I also do implantology. So when do I decide? How do I decide? There are so many questions in my mind, and those questions in my mind has come as topics of discussion today. So when do we say the retreatment has failed? Dr. L KRISHNA PRASAD is going to talk about. I first invite the moderators.
I invite the moderators, Dr. ASHITHA UPPOOR and Dr. KARTHIK SHETTY, to take their place. Dr. ASHITHA UPPOOR graduated from Naya Dental College, Mumbai, and did her periodontology post-graduation from Manipal College of Dental Sciences. At the present, she is the Dean and Professor, Department of Periodontology at Manipal College of Dental Sciences, Mangalore. Dr. KARTHIK SHETTY completed his BDS at the SDM College of Dental Sciences, Dharwad, and proceeded to complete his post-graduation from MCODS, Manipal. He currently heads the Department of Conservative Dentistry and Endodontics at MCODS, Mangalore, and he has practice restricted to restorative dentistry and endodontics at the Excellence Dental Healthcare, Mangalore.
So we have a periodontist and we have an endodontist as our moderators. Remember, no endodontic success can be defined if we do not go hand in hand with the periodontist. So periodontist and endodontist is at the moderator's desk. And next, introduce our speakers. Raksha, the first speaker, Dr. Sorry, they are speaking. Okay. Sorry. Can you call our speakers onto the dais?
Very good afternoon to everyone. We'll be starting with the second plenary session, which is on endodontic failures and retreatment strategies, a dilemma in decision making. And we have with us the speakers for today, Dr. L KRISHNA PRASAD, Dr. SHANTHIPRIYA Reddy, Dr. RAKSHITH HEGDE, and Dr. VASUDEV BALLAL. I request all the speakers to come onto the stage and take their seats on the dais. We also have with us three very erudite expert panelists, Dr. WADHWANI, Dr. GOWRISH S, and Dr. PREMALATA Devi. We request the panelists to please come onto the dais and take their seats.
Good afternoon, everyone. I think I have the pleasure of introducing one of the senior-most panelists, Dr. K. VADHWANI, Dr. Wadhwani has served as the Dean of Dental Sciences, King George Medical College, and alumni of the same institute, a recipient of the Gold Medal by King George Medical University for her contributions towards profession, and she's also nominated for the Bharat Shikshak Ratan Award. She has guided more than 100 postgraduate students. She has rendered her valuable services as President of Federation of Operative Dentistry and Endodontics, the President of Indian Endodontic Society, President of the Indian Dental Council, Lucknow, as member of the Union Public Service Commission. She also has to accredit various publications in national and international journals. A warm welcome to you, Madam.
As our second panelist, we have Dr. T. Premalata Devi. She is presently working as an Associate Professor, Conservative Dentistry and Endodontics at the Dental College Regional Institute of Medical Sciences, Impal, in Manipur. She has worked in Manipur Health Services as dental surgeon since 1996 till April 2013, and then joined the Dental College RIMS Impal as an assistant professor in the Department of Conservative Dentistry. She has participated as an expert member in Manipal Public Service Commission for Recruitment of Dental Surgeons, Manipur Health Services. She has acted as an internal and external member for BDS professional examinations. She is actively involved in scientific activities. She has given guest lectures in aesthetic dentistry and endodontics, and she has organized various CDE programs and attended various international and national conferences and chaired many scientific sessions. She has published many articles in high-impact journals, and at present she is a member of the academic subcommittee, Regional Institute of Medical Sciences, Impal, Manipur, Vice President of Indian Dental Association, Manipur State Branch, and the Secretary, IACD, Northeast Chapter. Welcome, Madam. We always from Manipal, when we see MANI, we read it as Manipal. So I'm sorry for the mistake. So the last expert panelist is a good friend of mine, Dr. GOWRISH. Professor GOWRISH Bhatt is an academician and clinician par excellence and is currently serving as an additional professor at A.B. Shetty Memorial Institute of Dental Sciences, Nitte. He obtained his BDS degree from the SDM College of Dental Sciences and Hospital, Karnataka University, Dharwad in 2000, and his MDS degree in Conservative Dentistry and Endodontics from the Savitha Dental College, TNMGR University, Chennai in 2006. As a private practitioner at Sparsha Medical Center, Mangalore, he has been rendering exclusive endodontic and aesthetic treatment since over a decade. His primary research, teaching, and clinical interests are interdisciplinary. He has numerous original research publications to his credit in index journals such as the International Endodontic Journal. Welcome, Dr. GOWRISH.
Who's the first one? Yeah. For this plenary session is Dr. L KRISHNA Prasad, and his topic is on when do you say the treatment has failed. A brief CV about Dr. L KRISHNA Prasad. He received his BDS degree from KVDC and hospitals, that is Dental College Sulia in 1994, and MDS from GDC Bangalore in 2000. He's the Vice President of the IACDE, Treasurer of ISPRP, Board of Study in the Rajiv Gandhi University, life member of the Indian Association of Conservative Dentistry. I think he's a life member of so many Board of Studies. I think I'll not go into it. And his special achievements were this: he's a second, third, and final BDS rank holder of Mangalore University, KVG Gold Medal awardee, and he was the best outgoing student of the same college, and he has also secured the TMA Pi Gold Medal awardee. and he has published around 60 national and international publications. Over to you, Dr. Krishna Prasad.
Thank you, ma'am. Good afternoon, all of you. My topic itself is a controversial topic. When you say root canal is failed. So I'm working as a professor and HOD in KVG Dental College and Hospital, Sulya. The aim of endodontic treatment is thorough debridement and cleaning of the root canal system of any infected pulp tissue so that the canal space can be cleaned and prepared and filled with the inert material to prevent or minimize any chances of reinfection. However, failures ensures when the endodontic treatment falls short of the standard clinical principles. To know the success outcome of a treatment, we should know what about success or failure. So in endodontic treatment. So when you say it's a failure, so commonly patient will say, I'm having pain after root canal treatment. The pain is persisting after completion of root canal procedure. We may say it is a failed root canal treatment. Or patient may be complaining of there is a swelling. Still it is persisting after root canal treatment for a long time. So we say it is a failed root canal treatment. And there is a purulent discharge, maybe through a sinus tract, which is not healed after our regular root canal treatment. Then clinically we may say it is a failed root canal treatment. So what are the reasons for this failure of root canal treatment? So iatrogenic errors like perforations, ledge formation, etc. Or it may be an untreated canal also. There may be 4 canals and we missed 1 canal. That may come up as a failed root canal treatment. And fractures, vertical fractures, it may be during or after the treatment. And endoperio lesions. And skill of the operator is also very important to have a good success. And poorly sealed restorations. The post-endodontic restoration is also very, very important to have a good success. So we can see in the diagram, there was a lesion, periapical lesion. After treatment, root canal treatment, still the lesion is persisting. So it is a failed root canal treatment. And there is a coronal leakage. Post-endodontic restoration, there is a leakage that leads to a failure of root canal treatment. Again, improper diagnosis and treatment planning also will result in a failure of root canal. And poor obturation, the quality of obturation, and incomplete debridement, it's also very, very important. And post-endodontic restoration, if you don't place, again, it's a failure. And systemic health factors like uncontrolled diabetes. You can see in the diagram the overextended or underextended obturation that might result in failures. So how will you clinically evaluate success? As an endodontist, you should be able to judge whether your root canal treatment is a success or it's a failure. So when there is no tenderness on palpation or percussion, no evidence of subjective discomfort. If patient is not complaining of any discomfort, then we may say it is a successful root canal treatment. And normal form and function of the tooth, whatever treated tooth is having a good function, and normal tooth mobility also. So this is about clinical judgment. And what about radiographic judgment? So normal or slightly thickened periodontal ligament space, reduction or elimination of rarefaction, and no evidence of resorptions, and normal lamina dura, and a dense 3-dimensional obturation of canal space. If everything is present like this, we can say it is a radiographic success. Otherwise, we have to correlate this radiograph along with the clinical judgment to prove whether it is a successful root canal or whether it is a failed root canal. These are the cases where we can see good obturation will have a good success. So in radiographic success also, there was a lesion and sealer has gone beyond and it's like a puff and having a good success. And ultimately, the final is a histological examination. If histopathological evaluation for success says absence of information and regeneration of periodontal ligament fibers and presence of osseous repair, repair of cementum, absence of resorption and repair of previously resorbed areas. But clinically in healthy condition, we cannot extract and do this histopathological examination. So we depend only on clinical as well as radiographic evaluation for success or failure of root canal treatment. So successful root canal treatment, clinical symptoms originating from an endodontically induced periodontitis like apical periodontitis should neither persist nor develop after root canal treatment. Once we diagnose there is a irreversible pulpitis with apical periodontitis, and after completing our root canal treatment, this apical periodontitis should not exist. Then we say it is a success. And the contours of the periodontal ligament space around the root should radiographically normal. The interpretation of radiographic findings without further considering clinical data does not appear sufficient to determine whether it is a success or failure. So we can say it is a complete healing or unsatisfactory healing or uncertain healing, or it is a incomplete healing like a scar formation. So when you say it's a complete healing, the bone cavity or when apical lesion was there, it is completely healed with normal bone tissue. And reformation of the periodontal space is there with the redevelopment of the continuous periodontal ligament lamina dura. Whereas when you say it is an incomplete healing or scar formation is there, so no signs or symptoms present at the follow-up time. A decrease in size of the lesion with incomplete resolution and a rarefaction with irregular periphery, often asymmetrical around the apex and demarcated by a compact bone border. So bone surrounding the rarefaction showing possibly a fine meshed structure or interspersed with the coarse bone trabeculae. When a regeneration proceeds, a lamina dura may be formed, isolating a circular rarefaction area in the bone. Then we say it is a incomplete healing or scar. Uncertain healing, we don't know whether it is a success or failure. So no signs of symptoms, but slight tenderness is existing. The initial lesion not resolved completely, but either remained the same size or decreased in size. And size of the rarefaction decreased up to twice the width of the normal periodontal ligament space. And this rarefaction may or may not be bordered by a lamina dura. Collar-shaped increase in the width of the lamina dura coronal to the apical radiolucency. Rarefaction circular or semicircular and symmetrical around the apex. And bony structure discernible within the bony cavity. Bone bordering the rarefaction has normal structure and radiopacity. So here we may not be saying whether it is a success. We are very much uncertain. Whereas unsatisfactory healing or failure cases, we say when signs or symptoms with the spontaneous pain or tenderness and or fistula is present, like pain is there, swelling is there, and sinus is there, where there may be a purulent discharge. Same as uncertain features, except the rarefaction size area is unchanged or enlarged in comparison to the postoperative or previous follow-up radiograph. So the diagnostic radiograph and after follow-up radiograph, if there is increase in size or there is no reduction in the size of the radiolucency, then it is a failed root canal treatment. So it has been reported that the prevalence of healing after root canal is around 80 to 86%. 97% of teeth were retained in oral cavity 8 years after initial non-surgical treatment. So endodontic treatment outcome, mainly healed means both clinical and radiographic presentation should be normal. And healing, it's a dynamic process and reduced radiolucency combined with normal clinical presentation. And disease means there is no change or increase in size of radiolucency. Clinical signs may or may not be present or vice versa. So factors causing the failures are mainly open apices cases, like 18% out of 76 cases, missed canal 12 out of 76, and insufficient enlargement biomechanical preparation, that is 10, whereas perforation caused 9 failure cases, fin and isthmus around 8 out of 76, transportation around 7 out of 76, residual caries 7, root fracture 5 out of 76, and inaccessible root apex and separated instruments resulted in 4 out of 76 cases for the failures. So mainly the success of endodontic treatment depends on removal of bacteria from the root canals and control of secondary infection. So to clinically meaningful, the concept of a failure should imply that the old treatment is not functional and should be replaced with another treatment. Factors involved include the presence of apical periodontitis and clinical symptoms, which both suggest more or less active root canal infection. So Bender et al. Discussed a success failure issue based on radiographic and histological findings and stated that only lesions that grow in size over the time should be regarded as their failures, whereas lesions that do not change should be regarded as acceptable. Friedman and Moore suggested that the term functional tooth as a third category in the debate of success failure of endodontic treatment. So I am having a case here, having 1-4, had a requiring apical periodontitis, required a root canal treatment. It was well obturated, but patient is presenting after 2 years, again having some tenderness. When you take IOP X-ray, the obturation looks normal, and patient had referred for CBCT also. CBCT is also there. Again, CBCT shows their apical, there is a lesion, and same lesion was there in IOP X-ray. So radiographically and clinically, because patient is presenting slight tenderness now, so we say it is a failure of root canal treatment. So I conclude. Thank you, Dr. Mitra Hegde and team, for giving me opportunity to speak about this topic, success versus failure in root canal treatment. Thank you.
Thank you, Krishna Prasad, for that concise presentation. Our next speaker is a periodontist, Dr. Shanthipriya Reddy. She graduated from A.B. Shetty Memorial Institute of Dental Sciences, and she has done a post-graduation from M.R. Ambedkar Dental College, Bangalore. She's currently a consultant at Manipal Hospitals, and she also has a private practice. She has been practicing implantology for the past 23 years. She's the author of the popular textbook, Essentials of Clinical Periodontology and Periodontics, which has 5 editions. She also has a book on mini surgical atlas in periodontics. Besides being actively involved in academics, she has numerous national and international publications to her credit, which have been extensively peer-reviewed, and she has delivered lectures in both various national and international conferences. Over to you, Dr. Shanthipriya.
Thank you, ma'am, for your kind introduction. I always forget thanking the organizing committee, so I would like to finish that first. My heartfelt thanks to the entire organizing team for inviting me today for this mega event. Thank you, Dr. Rupa ma'am. Thanks, Dr. Ramya, and my dear friend Mithra Hegde for inviting me to share my views today in this platform. So once we establish the tooth is failed endodontically, next step is whether to do the retreatment or extraction. How do we decide? Now, over the years, we have seen endodontic treatment has saved millions of teeth across the world. But unfortunately, despite its great success, few cases sometimes, unfortunately, may go into a failure. And this is an unfortunate reality. So what does it mean? Does it mean that all the teeth that has endodontic failure has to be extracted? No, most of the modern technology nowadays, what we have, including the microendodontics, advancement in the materials and the instruments, have given a great opportunity for us to treat most challenging cases with great success. And hence, the extraction of natural teeth is considered to be it should not be considered, and it should be considered only as a last resort. On the other hand, we have well-developed, well-integrated implants, which has also shown great success, and it has given multiple choices to the clinicians and the patients as well. So if you look at the reasons why the teeth have been extracted, when you look at the data, most endodontically treated teeth are rarely extracted due to the endodontic reasons. And the next is restorative failures, and then the most failures are related to the periodontal failures. The success rate of endodontic treatment is 97%, whereas the retreatment cases, we have a slightly lower success rate, which ranges from 77.5% to 95%. So as a periodontist, I would like to highlight some of the unique features of the tissues around the natural teeth and why it should be saved at any cost. So the tissues around the natural teeth have some unique properties or unique structure called periodontal ligament. So periodontal ligament is like a suspensory system and acts as a shock absorber, and whenever the forces are directed on the tooth, the ligament, which is hourglassed otherwise, widens, and then it distributes the forces to the neighboring bone. So the impact of the bone is minimized, and there is no loss of bone. The forces gets evenly distributed. So when you extract the tooth, this is lost. We can never get it back, even with the best of best options. Even with the implants, we can never have the periodontal ligament. Next is the gingival sulcus. So gingival sulcus around the natural, normal, healthy teeth, we have a very shallow gingival sulcus, which is around 0 to 3 millimeters. So the bacterial invasion or colonization, what happens in the sulcus, it stays there, and it is always kept far away from the deeper structures. And below the gingival sulcus, we have the junctional epithelium or epithelial attachment, which is attached to the root tooth cement-enamel junction. And below that, we have supraalveolar connective tissue consisting of various fibers and vessels. So all this, which we call this zone as a biologic zone, which is called as biologic width around 2.04 mm, is what helps the bacteria to be kept away from the deeper structures, and thereby the impact of this is the progression of the disease is naturally prevented. So next we have the orientation of the fibers. Now we have gingival fibers, around 9 bundles we have, and we have periodontal ligament fibers. The orientation of the fibers around the natural teeth is they are perpendicular to the root surface, whereas with implants or any other form, you don't have this kind of a perpendicular fashion, it's always parallel. So what happens if it is perpendicular, it blocks any kind of infection to spread to the deeper surface. So because of that, the minimal progression of the disease happens. And one more important thing is when we look at the gingivitis cases, many people suffer from gingivitis for years together. So they don't always develop periodontitis. So this is the natural defense or the barrier system we have, which is inbuilt around the natural teeth, and all this gets lost when we extract the teeth. Next important property is the healing response of the tissues around the natural teeth. It is richly supplied by the vascular blood vessels and the nerves, and any type of injury or any incisions we make, and it heals without any scarring. It heals faster and better healing with the natural tissues around the natural teeth, and also the regenerative response also is much better with the natural teeth. So when we remove the teeth or extract the teeth, all these unique features will be lost irrevocably and irreversibly. So now when it comes to the choice of whether to retain the compromised tooth or extract and replace, the guidelines are not very clear. So that is why the choice becomes very challenging and difficult. So the guidelines in the form of maybe meta-analysis or we have randomized clinical trials, there are very, very few and very sparse. So to get some kind of guidelines also is very difficult, and it always seems as if the clinician has to decide. So let us, in this part of the presentation, I would like to focus on the factors which my previous speaker has already explained, the how to group them into different zones, and then it can help us to make a decision. So whatever decision, treatment decision we make, it has to be patient-centric, and it should be long-lasting, it should be evidence-based, and it should also be affordable to the patient. This has to be kept in mind. So when we are deciding the retreatment options, there are some key or common factors which we need to take into consideration. One is age of the patient. Now when we talk about the patient's age, the younger individuals, it's always better to try to save the natural teeth because of the growth spurts. So when you decide to remove for whatever reasons, and if you have to place an implant, the position of the implant gets shifted because the patient's growth spurts, age, when they grow older, the position of the implants gets shifted. So it is always better to retain the natural teeth as much as possible in a younger individual. Of course, compromised medical history or medically compromised patients also, invasive procedures becomes very critical. Strategic location of the tooth should be considered. Quality of the bone and the soft tissue has to be considered. Aesthetic concerns, financial status, most importantly, clinical proficiency, clinician's proficiency. This is a very important factor which we have to consider. So when we divide or segregate various reasons, which again my previous speaker has already spoken about, we can just divide it broadly into restorative or endo failures with or without radicular region or periradicular regions, and another category where it is combined periodontal involvement. So this is the broad category. In the next slide, I am going to talk about various factors, how we can categorize it. Just for convenience sake, I have divided into 3 zones: green zone, orange zone, and red zone. In green zone, I have tried to put all the factors based on the evidence. I have collected the evidence and I have categorized the factors under green zone, wherein the data showed that you can get the maximum success rate with when you encounter with these factors. So endodontic factors, you have insufficient debridement, incomplete obturation, missed anatomy, coronal leakage. All these can be successfully rectified, and retreatment should be the option for these situations. Next we have periodontal consideration. So when you examine the periodontium, every tooth, before you do any treatment, it has to be probed around the sulcus, and then probing depth has to be measured. So if the probing depth is less than 5 mm, which is a mild periodontitis, or if there is bone loss which is just at the 1/3, and if there is a mobility, probably grade 1 mobility with furcation involvement grade 1, then we can think about non-surgical treatment and we can go ahead with the retreatment. There is no impact with the periodontal factor on your decision. Orange zone, here what happens is these factors, it can go either ways. It can go into a green zone or it can go into a red zone. So most of them are procedural errors, like iatrogenic factors, where there is a perforation of the root, or it could be instrument suppression, or it could be blocked or missed canals. So in these situations, especially perforations, if it is chronic perforations, if it is more coronal, the success rate comes down. But I'm sure with all this modern technology, microendodontics, which you people have been attending for past 2-3 days, it's going to be a excellent session for you all to learn the skills. So if you can use the microscope and perform these, definitely I'm sure that it can go into the green zone. But otherwise, probably you may have to consult an expert to do these procedures. Sometimes if you see the third X-ray, you can see that there is a perforation which was corrected, but then it entered into the periodontium and there is a bone loss and there is a communication with the gingival sulcus. These cases will be very critical. Many times you need a surgical treatment in these situations. Periodontal consideration, pocket depth which is beyond 7 to 8 mm, bone loss up to the middle third, and mobility grade 2, and furcation involvement again grade 2. This again nowadays we do it non-surgically. Treatment is only non-surgical, but sometimes in the inaccessible areas, posteriors or vertical bone loss, where we may have to do some regeneration procedures, we may have to opt for a surgical therapy. Otherwise, even these situation can be handled periodontally successfully. Now comes the red zone. So here endodontic factors, most of them have been categorized as root fractures, and vertical fracture, post-failure, root resorptions, there's a large apical cyst. This is a bit controversial. Anterior, still it can go into green zone or orange zone, but large periapical cysts, especially in the posteriors or cysts, very difficult to treat there. An unfavorable crown root ratio, severe periodontal involvement, all this goes into the red zone, and here we may have to opt for extraction. So when we look at the periodontal considerations, again here there is a severe periodontitis wherein the probing pocket depth is beyond 8 mm. Your probe is touching or reaching almost the periapical or the apical 1/3, and bone loss again 1/3. Mobility is grade 3 mobility with furcation involvement grade 3, and most of the teeth will be depressible in the socket, so there is no point in saving these teeth and you may have to opt for extraction. So I would suggest them to make a template keeping all these factors, create 3 zones and keep ticking whichever factor is in favor of either in the green zone, orange zone and red zone, and accordingly it becomes very simple for you to decide whether to go for a retreatment or to do the extraction and replacement. So to conclude, retreatment is definitely a case-by-case consideration. There is no single rule of thumb to say that this will work for all the situations. Every case is unique. Every case you have to decide what are the factors in favor of retreatment or against it, and identify all the warning signs. Most of the time you will know when you examine the teeth thoroughly, and as dental professionals or clinicians we have been trained to treat the natural teeth. So it becomes our moral responsibility to try and save as many teeth as possible. And but then at the same time, don't create any heroic attempts here. Herodontics should be avoided. When you know that the teeth are hopeless, it's better that you extract the teeth and replace them. So finally, I would like to say that implants are the best option for missing teeth, but not for the natural teeth. Thank you.
Wonderful presentation. I'd now like to call upon the next speaker in the panel, Dr. RAKSHITH HEGDE. Dr. RAKSHITH will be speaking about retreatment versus dental implants. Dr. RAKSHITH is currently serving as a professor in the Department of Prosthodontics at the A.B. Shetty Memorial Institute of Dental Sciences. He has completed his BDS and his MDS, both from the A.B. Shetty Institute of Medical Sciences itself. He is an author of a textbook, Essentials in Oral Implantology, and he is an education delegate for ITI India section since 2018. He is a fellow of the ITI International Team for Implantology, and he is a KOL for Straumann implants, Dentsply Sirona implants, and Geistlich Pharma. He has attended numerous training courses in India and abroad, so that is a long list to get into. But I welcome Dr. RAKSHITH HEGDE, my good friend, as the speaker, and RAKSHITH, the stage is yours.
Thank you, Dr. Karthik, for the introduction. I would like to thank the organizers, MITHRA madam and team, for giving me this opportunity. Well, this particular treatment is close to my heart for 2 reasons, because my wife is an endodontist and I'm an implantologist, so you know how it works. We do have to fight. Well, it is this institution which has brought me up to this level. So I owe a lot to this institution, great institution, because it is this institution which has given me a free hand to work and learn at the same time. Well, when it comes to retreatment or to go in with implant placement, it's very, the decision making is very, very critical, because I'm not a person who would like to extract something which is natural and then go with something which is artificial. Well, when it comes to retreatment, we need to have a lot of strategic considerations, especially when you have to do a retreatment or when you have to extract a teeth. There are a lot of components that we need to look into. It is not just the endodontic component, but we need to look at the prosthodontic component. We need to look at the periodontal component. Of course, Madam has spoken about the periodontal component. So what are considerations that you need to look into? I might slightly overlap, but I'll try and keep it without any overlapping as far as possible. Well, this is from an article. If you had to look at this particular picture here with the molar, what do we see here? We see that this particular molar has got an apical periodontitis with a grade 3 mobility, and the adjacent teeth are having some kind of a sensitivity issues, but there are no caries, and the probing depth is about 2 to 3 millimeters, mobility is 0. So this is what the initial situation is. In this study, there were a lot of people from whom the questions were asked, from a general dentist to a periodontist to an oral surgeon and a prosthodontist, and of course, when it comes to the age group of the dentist also, a lot of questions were asked. And what is the finding that we see with this? You know, when it comes to a particular treatment, the decision making is different with different people. When it comes to a periodontist, he would start thinking from a periodontal point of view. When it comes to a prosthodontist, he would think from the prosthodontic point of view, and an endodontist would definitely think from the endodontic point of view. And of course, a general dentist or an implantologist or an oral surgeon would always like to extract and then place implants. So this is what we generally see. What do we see is there is close to about 55% of the people, especially the prosthodontists and the surgeons, who told that they would extract and then place the implant. So this is what the prosthodontists or the oral surgeons would try and look into. But when you look at a periodontist, what does the periodontist would do? Would like to save the teeth. So, you know, only 35% were for extractions. So we see a large difference. So what do we have to do? Actually, it's best to have an interdisciplinary approach. Take the concern of the different specialists and then come to a consensus, what would be best for the patient. I think for us, patients should be the center. It should not be our decision overruling on what the patient really should get. So keeping the patient in the center, I think it's best that we would give the treatment plan according to that. When it comes to whether to treat, extract, or replace a questionable tooth, when would you look at restoring a tooth? When you have good, sufficient tooth structure. This is when you would try and restore the tooth, and also there is no periodontal issues which are there, then you would go and restore these kind of tooth. But when you have very minimal tooth structure, or when the resistance form of the crown is going to be very, very minimal, you need to be slightly careful. So we could improve the questionable tooth to a good tooth sometimes by doing a good post and core treatment and then improving the quality of the teeth. This can be done, or sometimes even a crown lengthening procedure can improve the surface area of the tooth, and then you can give a better treatment to the patient. But there are cases where you don't have any tooth structure. In these kind of cases, doing a crown lengthening or doing a post and core is useless, because what you're going to do is you're going to just delay the failure of the teeth, might be by a year or two. But in this year or two, when there is a failure, there is going to be a lot of bone loss which will take place with this particular tooth. So is that good for the further treatment? It is definitely not good, because what's going to happen is when there's going to be failure with these kind of clinical situation, then there is going to be loss of bone. And with the loss of bone, the patient needs to add an extra amount, especially if the patient wants to go in with an implant supported prosthesis, because then the patient needs to go in with grafting procedures to get the volume back into what was earlier present. Because it's good to get the volume back, because if the volume is not back, then the patient would develop foot impaction on a later date, because you're going to affect the contour of the tooth is going to change. There's going to be the placement of the tooth might be apical to the adjacent teeth, which might interfere with the form of the gingival embrasure. So you need to see to it that you don't do that, and then you need to take the decision at the right time. When it comes to an optimal abutment teeth, I think an optimal abutment teeth is definitely a non-root canal treated teeth. But if there is a root canal treated teeth, or if the root canal treated teeth are done on a tooth which was vital, then you have more success when you do a fixed partial denture. So you don't have to really bother about it. Where the success rate goes down is when it's a retreatment. With a treatment done on a root canal treated teeth, which is having a vital tooth without any apical periodontitis, the success is much, much better. So we see that the success varies according to the type of patient that you're going to treat, and also according to the amount of apical infection which is there. As a prosthodontist, this is what we look into, the height and diameter ratio. We need to have a good height and diameter ratio. The height and diameter ratio needs to be at least 3:7. If this height and diameter ratio is not good, then you're going to have a failure when it comes to the prosthetic treatment. And also, if you're looking at doing a post-encore treatment, especially for a fractured tooth, then we need to see to it that there is enough ferrule. So if there is not much of a ferrule, then again, we would definitely see failures. When it comes to long-term success of FPD, what do we see? We see that when it comes to a FPD, it does last for about good 20 to 30 years of time. But we do also see some failures. So where do we see failures? We see failures especially with the endodontically treated teeth after 20 years. So that's a good time. I'm not telling that it's bad. So endodontically treated teeth do last when used as an abutment for a good 20 years of time with 57% of success. But if it's a vital tooth, it lasts, the tooth would last for about, most of the time, about 75%, 77% of the abutments do last. When a tooth is endodontically treated, what happens to the tooth? It loses its stiffness, and it becomes very brittle. So the chances of the tooth fracturing is much, much higher when you have a tooth which is endodontically treated and also which is prepared. So when it comes to the failures, what do we see in failures? These are the common failures that we usually see. That is, 22% of the failures are because of caries, that is secondary caries, 15% because of loss of retention, 24% caries and loss of retention. So this is what we usually see over a period of 10 years. When it comes to a vertical tooth fracture, the vertical tooth fractures are more with the non-vital teeth when compared to the vital teeth. And especially if it's root canal treated teeth, and what we see is you have failure, a vertical fracture close to about 48 to 68%. And where do we commonly see these failures? We see these failures commonly in the mandibular first and second molar region and in the maxillary premolar region. This is where we usually see the failures. When can we keep the root canal treated teeth? When we see a complete and advanced healing after root canal, that is after 4 years, you can keep it. If there is a periapical infection in 4 years of time, this tooth becomes slightly questionable. Root canal treatments are almost 100% success, has got 100% success, provided it's done on a vital tooth. If the tooth is initially vital, that is, if there's pinpoint exposure during preparation, or if the tooth has just got infected by a small exposure of the, then we do have close to about 100% success with a root canal treated teeth. At 10 years, close to about 95% success. So that is what we usually see with implants also. So it's quite good. But things do change if we are looking at a patient having a periapical lesion. If there is an apical periodontitis, then we don't start with 100% success. We start with 0 when you do a root canal, and then might we go up to 86%. So this is what we see at 10 to 17 years of time. Now, do we have to really save this sometimes? The clinical decision needs to be made when to save and when not to save a patient who is having a apical periodontitis. So in these patients, if I had to go and place an implant, from where do I start? I start from 100%. And what do I, maximum failures, what we see is might be about 4% of the failures in these kind of cases. So it's always good, I would say, in a patient who has got apical periodontitis, especially in patients who have got intrusion of the teeth, to extract and then go ahead and then do the implant placement. Might be immediate, might be delayed. Immediate, you could do it if you have been doing immediate loading cases for quite some time, because you need to make sure that you have curated out very nicely, and then you go ahead and then you could do the implant placement on the same day itself. Post and co, of course, is a good thing to do for an endodontically treated teeth if you want the teeth to last. So is it good? Yes, posts are good to go ahead with. You could go in with the cylindrical post. I would recommend cylindrical post to most of my patients. FRC cylindrical post is what I like to have for my patients. What are the big question that we have today is that, is endodontic treatment successful or retreatment feasible? Can we restore these teeth always is the big question, especially for a patient who has a tooth which is fractured almost at the apical aspect. Can this be always restored? What are the efforts and what is the cost involved in restoring this? And is it worth it when compared to doing it with implants? And can this abutment teeth be used as for a fixed partial denture, especially if there's a loss of tooth on the adjacent area and if there is a fractured tooth? If you have to do a post and co and then go in with the tooth as an abutment, would this abutment last? Or is there a contraindication for endodontics or for implantology when you have a clinical scenario which is having a periapical lesion? So we need to look at all these things. When we have a fracture of the tooth, then what we usually do is we might end up with doing a crown lengthening procedure and also going in with a post and co treatment, and might be a little bit of periodontal therapy and then shaping the crown in such a way that the margins can be defined well and there is no plaque accumulation which will be there. In these kind of teeth where you have a fractured tooth, might be a post and co can last. Might be. It is not always that the post and co's do last, because especially with the metal post in the anterior region, this has got sometimes a detrimental effect, because what happens with the metal post in the anterior region is that the forces are not transferred along the long axis. The forces are transferred horizontally, and this horizontal forces can cause a fracture of the anterior teeth. Whereas in the posterior, the metal posts are quite good enough, especially a cast post is quite good enough. But when it comes to an anterior, the metal post might not be very good. An FRC post would be much better. Looking at the periodontal status, also we need to decide whether we can save this teeth. It is not just endodontic, but also the periodontal status. When we have bone loss which is there, and almost about 70% of the bone loss which is there, then I think it's best to extract, or in a case like this, I think it's best to extract rather than going ahead and then doing a periodontal therapy in these kind of situations. What is safe is when we have less than 3 millimeters of bone loss which has taken place, and questionable is when we have about 50% when the bone loss has taken place. So, but a 50% bone loss, when it takes place, you could always regenerate it back by doing a proper periodontal and endodontic therapy sometimes. Sometimes, we need to look at both endoperio way of going ahead with the treatment. The data also tells the same, what I'm trying to tell you. So what do we look at when it comes to the strategic considerations in treatment planning? When it comes to an anterior teeth and a posterior teeth, it's quite different. When it comes to an anterior single-rooted teeth, the treatment plan is different when compared to a treatment that you would like to do for a multi-rooted teeth. Simpler anatomies are much easier to treat, especially endodontically, when compared to curved canals or when there is a lot of accessory canals. When it comes to tooth maintenance, there needs to be enough bone. So if you had to prolong the treatment for a very long time trying to save the teeth, you might lose all the bone, and then for placing implants, there might not be any bone left. So we need to look at the patient's benefit. As I told you when I started off with my lecture, we need to keep our patient in the center and then think what is the right treatment for this particular patient. If we had to look by literature, does implant affect prosthodontic outcome? Yes, implants do affect prosthodontic outcome, but in a positive way. So what has happened is, over the years, we have stopped making long span bridges. So where are we now today? We are we are in a situation wherein we place implants in the edentulous areas, partial edentulous area, and try and make crowns and bridges with the implants rather than making long span bridges. If you had to look at this particular case scenario, about 25, 30 years back, someone would have used these 4 abutments and then made a long span bridge from molar to molar. This is what people would have done it. But then the failure rates are high when you use just 4 or 5 abutments for a very long span bridge, especially when it's a cross arch situation. You don't have good results. So it's best to put in implants in between and then go ahead and then you could get better treatments. So there was this study which was done for about 10 years, 2 groups, where the initial group was from 89 to I think 99, and then 97 to I think 2007, something like that. The study was done. So in this study, what was seen was the amount of failure was much less where in the recent years. The reason is more and more implants are being placed. So when you see more and more implants being placed, you have less amount of fixed dental prostheses failing. I'm just going to show you 3 cases because I've hardly spoken about implants. So now I'll show you 3 cases of implants where we have placed these implants for looking at the patient's age and also the condition at that particular time. So this is a case where there was a fracture in the canine at the cervical aspect. You could go in with the post-in core and try and restore it, but then there is a chance that this tooth will fracture because there is a lot of load on the canine which will be there, because whenever the patient moves the mandible laterally, there is going to be a lot of load transferred onto the canine, so they can fail. But most important thing in the anterior zone is whenever you are placing an implant, it's 100% necessary to make a CBCT. The reason is the buccal bone is very thin. I would say 90% of us have got thin buccal bone thinner than 1 millimeter. So when you have a buccal bone which is thinner than 1 millimeter, this bone is as good as a deficient bone in the buccal aspect, because this bone is 100% going to resorb. And what do we see is a gray hue of the implant in a question of 6 to 8 months of time. 6 to 8 months of time, you're 100% going to see a gray hue on the buccal aspect. So if you don't want a gray hue to be there, you need to augment at the same time. So we extract, place the implant. So this buccal bone chips which are there, which is very thin, is always removed out, because you can use this buccal bone chips as autogenous chips on the surface of the implant, and then you could augment it with augmentation material of your choice. My choice of augmentation material is usually either an allograft or a xenograft material. I like the xenograft better than the allograft because it does maintain the contour, and a good collagen membrane needs to be close, preferably in 2 layers, and then you could come back in just about 2 months of time and then do the second stage surgery and then go ahead and then do the restoration. So what do we see here? We see that a good buccal bone has nicely formed. So it's important to regenerate this bone, and this regenerated bone needs to stay there. An anterior area where you have a fractured tooth. We need to, as I told you, preserve the buccal bone. But most of the patients, 90% of the patients would have less than 1 millimeter of buccal bone. So in this particular case, we did do it in a slightly different way. We extracted only partial tooth. Partial extraction therapy was followed. So only the palatal aspect of the root was extracted. You could see the buccal shelf of the root being still preserved. And then this is what we do. We just extract only the palatal aspect. The buccal shelf is held on to the bone which is there. It is this first 6 to 7 millimeters of bone which usually resorbs. After that, it does not resorb. So what happens is when the shell is maintained, the periodontal ligament is still maintained there. So when the periodontal ligament is maintained there, there is no resorption on the buccal plate which will take place. So a partial extraction therapy is good in some of the cases, especially if it's if the tooth is not infected, and then you could go ahead and then load the teeth immediately. This is an immediate load case, and then the patient can come back, and then we go ahead with the final prosthetics. So this is how the final prosthetics would look like. So if you look at the emergence profile, the emergence is exactly like the adjacent natural teeth. So it's important that we have the same emergence like the adjacent natural teeth. another controversial case. I think this will be interesting for might be to discuss. A case where there's a periapical cyst. So most of the time we do extract, and endodontic treatment was not possible in this particular patient because the lesion was quite big. If you had to look at this particular case, so what we planned was about 4 implants in the anterior region, might be 1 in the posterior. So this is what was planned. This is the status of the patient's teeth, wherein endodontic treatment was not possible in this particular patient because there was calcified canals, and then it was not possible for the endodontics to be done. So after extraction and enucleation of the cyst, you can see here in this area, this is after enucleation. This is how it looks like. You need to make sure that you completely enucleate, and then you could go ahead and then place the implant at the same time, provided you're 100% sure about the enucleation, what you had done, and then you could replicate the same what was planned in your final implant placement, and a temporization is being done. So what do we see here is, might be after about, I think I recall the patient back after 6 weeks for the permanent prosthesis. This is all that I wait, not more than 6 weeks, because 6 weeks is more than enough when you're using a SLA active implant. You don't need more than 6 weeks for integration to take place. In fact, integration takes place in 3 to 4 weeks of time. I give an extra 3 to 4 weeks for extra healing to take place, for the remineralization to take place in that area. And then we go ahead and then load with the permanent prosthesis. If you had to look at the CBCT images, you could appreciate the amount of bone which is formed, especially in the area where the cyst was present. What was used was just the bone chips from the patient's own side, that is from the mental region. The bone chips were used and then regenerated without using any other graft material. So this has happened in a question of this. This patient did come back for a replacement of the upper anterior teeth also with implants, because there was a periapical lesion. You could see the periapical lesion, in fact, in the canine, in the CBCT upper canine also. There's a big periapical lesion. So the patient did come back for implants for the upper teeth. So what can be done is you could do an immediate implant placement and still regenerate bone at the same time. So all you need to do is follow simple protocols, and if you follow simple protocols, I think it's possible to regenerate bone. I think it's even possible to regenerate bone when you do an episectomy. When you do an episectomy, and if you had to close it with the membrane, I think most of them don't close it with a membrane. You just leave it without a membrane. So what happens is there is the epithelium migrates into that area, and then you have the periapical area filled in with tissue which is never going to regenerate. So if you had to have a blood clot in the periapical region and a membrane which is closed with double layers, I think you can regenerate bone without using any graft material. All you need is a good membrane. If you use a good membrane, then you can regenerate bone even for your apical periodontitis case, where if you have done a episectomy and then you're trying to regenerate bone, I think it's possible to do that. Thank you very much. Thank you, madam, for giving me this opportunity.
His PhD degree in endodontics from the Manipal College of Dental Sciences, Manipal itself. He has created new vistas by collaborating with several renowned international universities and has conducted more than 45 projects. His expertise in the field has authorized him to hold the post of an editorial board member of 23 international and national journals, including the Journal of Endodontics and the International Endodontic Journal. He's a reviewer of 82 international journals and 5 national journals. He is the only Indian who has received the Best Reviewer Award of the top 10 percentile in the world by the American Association of Endodontists and Elsevier Publishers in 2014. He has been awarded 11 times as an outstanding reviewer for the Journal of Endodontics by the American Association of Endodontists. He has received thrice the top reviewer in the world Dentistry Award by Publons Academy, UK. He has reviewed more than 550 plus manuscripts for various international journals and is the top reviewer in India in the field of dentistry. He has 150 international publications and 25 national publications to his credit, and his topic of profound interest is on root canal irrigation, intercanal medicaments, root canal disinfection, and endodontic biomaterials, rendering to which he was the first to explore the use of malic acid as a de novo root canal in the endodontic specialty. I present to you Dr. VASUDEV BALLAL.
Thank you, Dr. Karthik. I think you're tired. At the outset, I would really like to thank MITHRA Madam and the entire team for calling me to share my thoughts, because I feel something different, because unlike all the speakers, I am not a practitioner. Okay, that is the first point. I want to clear it out. I am not a practitioner, but I am a core researcher. When Madam gave this topic, I was in slight dilemmatous area, because I talk only the area which I work in. But since Madam told it is a 15-minute talk, actually it went on to hours in the morning. It was a 15-minute talk. I have just kept my presentation very short. What I want to tell is, like, my half the presentation, more than 80% of the presentation, I think Dr. Krishna Prasad sir has already told, and he's made my job very, very easy. Thing is, my talk is based on evidence, because I always believe, I don't know how many of you practitioners are with me, but I always believe when we do any endodontic treatment or restorative dentistry or anything for that matter in dentistry, there need to be evidence. Otherwise, we will never come to a conclusion like which treatment is the best. So if you see the clinical scenario, what is happening in the world, just for 2 minutes I am telling you about what is happening, which is apart from my topic. If you see the American side, if you see the European side, all consensus statements are coming now, especially for postgraduates who have to read all this during your PG time. So they derive at a consensus based on the evidence. I think in India also we need to incorporate that, especially in any specialty, in endo especially, where there is a lot of controversial issues. Each one of us do our own way of managing a case without a clear-cut evidence. So I always believe there should be an evidence, because in August, European Society of Endodontology is coming with the S3 level of evidence. That is the highest level of evidence what an endodontist can achieve. So ideally we need to follow that, but it is in the area of vital pulse therapy. Why I'm telling you all this is, evidence-based dentistry is the in thing. In medicine it is already there. But in dentistry, I don't think most of us won't practice evidence-based dentistry. So what I'm telling today, because my topic is very, very controversial. Like, there is no as such clear evidence to say which one to go for surgery, which one to go for non-surgical. Because to be frank, there is, as Madam also said in her presentation, there is no enough well-controlled clinical trials, which is the highest level of evidence, has been conducted in these retreatment strategies. So what you see is all case reports or 1 or 2 studies, which is very poor level of evidence. So as such, there is no clear-cut evidence to say, but we'll go through some of the slides what I have shown you. I have collected as much as possible evidence, even though it is very minimal. There were only 2 systematic reviews and meta-analysis conducted, one by Dr. Turabirajat, I think is a big name, everybody know. But problem is, his evidence was in 2009. So 2009 to 2022, there is a lot of changes in endodontic armamentarium. In every aspect, right from access to the post-endodontic restoration, lot of changes have come. So we cannot take that evidence as the best evidence for 2022, because 2009 and 22, a lot of gap is there. But still, some of the evidence, what he is shown in his systematic review, and one more recent systematic review has come in Curious Journal, Algamadi. Again, it is not a high level of evidence, because the study, what they have checked is only for 3 studies. Because systematic review is supposed to be the highest level of evidence. So why I'm telling you all this is because there might be a lot of debate on the topic what I'm talking, but there is no clear-cut evidence to say which one is the best. We'll flip on to some things. Already Dr. Krishna Prasad has said what is success and what is failure. So it is like similar when we say success and failure for a primary root canal treatment, it is almost same for the retreatment cases also. So I have kept it in very short. When you can say a root canal is success, the broad thing is patient is asymptomatic. That is what we always first see, right? When the patient comes, no unta, no, that means you are done. So that is first thing what we say, pain. Second thing we see for a radiograph, is there any radiographic evidence of failure, whether resorption or periapical lesion existing or new lesion coming, everything. And last thing we see already if the lesion is present, whether it has reduced. So these three are the basic thing in a broad area I am telling you. Sir has already said in detail about radiographic evidence. We need to see all these things and then we can say that the treatment what you have done is a success or failure. When you say a failure, again when the patient is symptomatic, that is again after 48 hours. Again, the research has shown there are multiple studies which have done after primary endodontic treatment to see the pain level, and they say first 48 hours pain will be there, whatever type of treatment you use, whatever type of gadgets you use. So first 48 hours, if the patient says he or she has a pain, you cannot consider it as a failure. But after 48 hours, if the patient has the pain, yes, you can think of a failure. Then the radiographic evidence, again, you have to see a lot of things, as sir said, right from periapical lesion to resorption, etc., etc. Then the most problematic area where it comes is this questionable area. It is very dilemmatous area sometimes, where we see it is a state of uncertainty. There will be a lesion, patient is asymptomatic, lesion is not healing. This is very, very dilemmatous area where some say I'll go for surgery, where some say I don't go for surgery. So I will tell you with evidence for such cases what the evidence says. Why do root canal treatment fail? This is again why we need to know this. My topic is retreatment. Sir has already said why I am telling you this is because whenever we do a secondary retreatment or a secondary root canal treatment, all these factors what I have mentioned here we need to consider. Because treating second time a root canal is always much, much tougher than cleaning first time. That also evidence is there. So retreatment is always challenging. So there might be improper disinfection. So the majority of the cases what the literature says the root canal fails is because of improper disinfection. Okay, we can talk a lot on this, how to properly disinfect the canal, etc. But this is a broad area where most of our root canal fails. Then obviously there will be some under obturation or over obturation, endoperio lesion, very common etiology we usually endodontists neglect, missed canals, iatrogenic errors and improper coronal seal. So out of all this, if you see the evidence based, if you are asking me, improper disinfection is the most crucial factor where a primary or a secondary root canal treatment fails. Now coming on to the retreatment, what do you mean by retreatment? American Association of Endodontists has given some glossary terms. In that they define retreatment as a procedure to remove the root canal filling materials from the tooth, followed by cleaning, disinfecting, shaping and obturating and giving the post-endo restoration. That is what we simply say retreatment. But every aspect of this has been laid enough importance, right from opening the re-access of the cavity from the microbial control till the end of the obturation and giving the post-endodontic restoration. Now again, if you see this slide, okay, everybody knows, as sir also told, clinical radiographic. That is a common clinical evaluation, what we do when a patient comes to us. But CBCT, that CBCT is the one tool which has changed the entire diagnosis and the outcome in endodontics now. If you see the literature by Dr. Patel from KCL London, he has done a lot of studies on periapical healing using CBCT. There is enough good systematic reviews recently published in BDJ. Okay, what they say is there are so many lesions which are not seen in radiograph, but they are detected in CBCT, which usually we don't detect. So we do a good obturation, we put the photographs in FB because we want to see all white lines, puffing and lateral canals, etc., without any evidence whether to fill or not. We still don't have an evidence, still we want to fill the lateral canals, and we see that when the patient comes back to us, there is nothing, absolutely fine. But the patient says he or she has pain, and we are just wondering why, because radiographically it is perfect. They have seen all these cases, all these type of cases which were coming to King's College London. They have done a very beautiful study, and they compared radiographic versus CBCT, and they saw there were some hidden lesions in the periapical lesion detected by CBCT which was not detected by radiograph. And when they opened and saw there was a periapical infection. That is why I'm telling you CBCT is one of the in thing. I do agree for every case we cannot take a CBCT for the patient because of the radiation exposure, but whenever there is a dilemmatous situation, especially when the primary treatment fails, it is better to go for a CBCT. Then you might ask histology. Already sir said, histology we cannot do, clinician, right? But why I have put histology? Because if you see a lot of good articles by Domenico Ricucci, who is one of the world's best histopathologists. He's not an endodontist, he's from a private practitioner in Italy. I had discussed with him, very difficult to talk to these people, they'll never reply you back. He and Joe Sequeira, I think PGs must be knowing this name, very, very god of microbiology in endodontics, Joe Sequeira from Brazil. They have done multiple studies why the tooth fails. You know, we like when the patient, well, either perio prognosis is poor or endo prognosis is poor, finally we send it for extraction and then we give an option. Yeah, you go for an implant, etc., etc. But we never think why the tooth which I obturated three-dimensionally so beautifully failed. So what these people have done and are doing also, they extract the teeth and they do beautiful histopathologic and histomicrobiology study and they see where and all infections are there. And majority of the cases, what they saw was the lateral canals and accessory canals and apical ramifications, which were filled in the radiograph. That is why I say we do a lot of treatment without evidence. That is very common trend in PGs to puff the sealer, to do and put the obturating material into the lateral canals and show to their teachers, see ma'am, sir, I have done beautiful obturation. But there is enough evidence to show this does not have any role. Bacteria still is there in the lateral canals. So that is where histologic evidence plays a major role. I definitely agree in a clinical scenario we cannot, but if somebody is interested in research or if you want to know why the tooth which you have done has failed, always you can do a good histology if you have an histopathologist in your college. Now, when do you perform a retreatment? There are some, again it is a dilemmatous area where we need to do a root canal retreatment. So some of the indications given is persistent periapical radiolucency. I'll be talking about this in my next slide based on evidence again. So if there is a persistent apical radiolucency, you may have to think of a retreatment. Tenderness on percussion, again I'm telling you after 48 hours. Whatever it is after 48 hours after your primary endodontic treatment, if the tooth is tender on percussion, you may need to go for a root canal treatment, but you need to consider the fracture of the tooth. So if the tooth is fractured, if there is some endoperio lesion, first you need to think that. But if you can solve all this, but still the tooth is tender, you can go for we might think to do a re-root canal treatment. Fistula formation is another indication. Swelling of the surrounding soft tissues. That is where endoperio lesion comes. There are some contraindications where we need not try to attempt because it might be a failure. One is a vertical root fracture. Again, if you see the literature, there are so many treatment options, but where there they have tried to save the tooth, but again, it is all case reports. Remember that. It is just 1 or 2 case reports which they have tried and they have seen for the healing, but there is no longitudinal long-term studies about saving a tooth where the tooth was fractured. So vertical tooth fracture usually goes for an extraction. Poor periodontal status, madam has already spoken on that. Difficult access. So sometimes retreatment is very difficult when we already give a post-endodontic restoration. If you don't have a good access where we need to drill inside the crown, etc., it is better not to try unless and until you don't have a good expertise. Anatomical limitations. Again, the very curved canal. Treating primary canal which is tortuous is still easy with all the latest Nitte instruments. But the same thing treating for the second time, removing the guttapercha in the tortuous canal, it is not at all easy. That is again a question of debate. How will we remove guttapercha? It is very, very difficult to remove the guttapercha in the tortuous canal. Again, if you see evidence, canal is never 100% free from the obturating materials which can harbor the biofilm and cause reinfection. Again, non-restorable teeth. That is again one of the other classical contraindication for retreatment. Now again, treatment strategies. This is the topic which was given for me, okay. Broadly, everybody knows non-surgical and surgical. So if you see the success rate, as I said, whatever success rate I am quoting the article, it is again not a high level of evidence. It is just based on 2 systematic reviews, that also only minimal 2 to 3 studies. So it is not a very high level of evidence, but still there is some evidence on surgical versus non-surgical. So non-surgical treatment, they showed 76% evidence for 4 years. Surgical, they showed for 72% in 4 years. Now, this is where the real dilemma comes, or the debatable topic comes, when we need to do surgical, when we need to do non-surgical. So whatever literature I have supported, I have collected based on the evidence, I will give you a flow chart where we need to do a retreatment. This very much problem, this happens, as I said, when the patient comes to you with a periapical lesion. Otherwise, there won't be much of debate whether we need to do surgery or non-surgery. But when there is a periapical lesion, when the patient is symptomatic, there is a lesion, we will be in dilemmatic situation. So if the patient comes, a symptomatic patient comes with a periapical lesion, whether the root canal system is completely well obturated 3-dimensionally or improper obturation, you can broadly divide into 2. That is, 1, patient seeking immediate results. The patient might say, usually in our Manipal, this is a common thing. Patient comes from abroad, from Gulf country for the vacation, and they say, I want my treatment in 1 week. Next week, I'm going back to Dubai or etc. So in such cases where the patient needs immediate result, 1, you cannot recall the patient back. It is better you go for non-surgical followed by surgical. But always remember, based on, again, evidence, non-surgical should be always your first treatment of choice. You cannot do directly surgery even though you think the root canal, what is obturated, is good. No, they say there will be some errors, or there might be some biofilm or microorganism entangled in the ramifications, which is again good histological evidence is there. That is why they say it is already better you do a retreatment first, then you go for a surgery. That is if the patient want a immediate result. This is the evidence I am telling you, okay, Torabinajad's systematic review. But when it is long-term success, if the patient is ready to come every 6 months or every year, what the evidence says is you go for a non-surgical intervention only and wait up to minimum 4 years follow-up. Now, I am not sure about the practitioners, whether they can recall the patient or not, that the practitioner should decide. But European Society of Endodontology in 2006 has given a consensus statement based on a lot of retrospective studies what they have collected, and they have seen minimum 4 years recall is a must if there is a periapical lesion after doing non-surgical intervention. Whether you can recall the patient back after 4 years, especially in India, it is very difficult to recall the patient, unlike abroad where they have everything connected to the government, where the patient can directly come to the clinic or a hospital through the government. But in India, we don't have such facility. So recalling a patient back might be difficult. But if the patient is local or anyone, if the patient says yes, he or she can come back, it is always you recall the patient, wait and watch up till 4 years doing non-surgical intervention. So after 4 years, then what? So the patient comes back to you, okay? After 4 years, there will be a periapical lesion. So now what will you do? Again, there might be 3 situations when the patient comes back to you after 4 years. One thing, the lesion might reduce in size. Okay, it might be fully reduced or it might be partially reduced. If you see the evidence again, they say healed, completely healed and healing lesion, both they consider it as a success if the patient is asymptomatic. So what they say is partial bone fill can lead to apical scar, and that is also a success. It need not be complete resolution of the lesion. If the patient is symptomatic, yes, then it is a success. But it can be a failure where the size increases. So post-year, 4-year follow-up, when the patient comes, if the lesion size is increased from pre-operative, you can call it as a failure and you have to directly go for the surgical intervention. But in between, if this situation comes where the size is the same, that is what I said before, here it is a very debatable matter. What to do? Whether you need to do a retreatment or you need to wait and watch again. Patient is completely asymptomatic. There is no evidence in literature telling what you have to do if the patient comes with this type of lesion. That is why I said whatever I am talking is based on evidence. I am not sure what is a practitioner's choice if the patient comes like this. But I believe in doing any treatment based on evidence. Again, what they say, if the patient comes on this where the reduction is not there, wait and watch. Don't intervene for surgery, because always they say surgical success is always less compared to non-surgical therapy. So if you can wait and watch, you can. There are some case reports where they have called patient for 24 years follow-up with the periapical lesion. Again, it's a case report. I am not telling it is a high level of evidence, but still they have seen for 24 years follow-up where the lesion has healed. So you cannot say if the lesion is not healed in 4 years, your primary endodontic treatment is a failure. No. You can call it as a success. You have to recall the patient back and see. Same thing holds good in everywhere. When we do a vital pulse therapy, also, we need to recall the patient and see, which we hardly do in our clinics or in our college. So this is where my actually topic ends now. Okay, so you all know when to do a surgical, when to do a non-surgical. Okay, there is a big gray area when the patient comes back to you with a long follow-up where there is no symptoms, but still the lesion is present. Evidence says don't do anything, but the practitioner's choice we need to debate. But whether you do a non-surgical or whether you do a surgical, you need to think of all these risk factors when you do, because every risk factor has shown to decrease the success rate of retreatment of endodontics. First thing is the improper removal of the root canal filling. Again, this is a big debatable topic, and you can see hundreds of lab studies keeps coming in. How to remove gutta percha. Everyone is trying with different instruments, but ultimate result is what? Nobody can remove 100%. That is one. Improper disinfection. I already told you, majority of the cases fail primary endodontic or secondary endodontic is because of lack of or improper disinfection. Size of the periapical lesion. They have checked for this also. They say if the diameter of the lesion is more than 5 mm, usually the success rate is poor compared to lesser diameter. Tooth type and morphology. Complex root canal system. Lower molars, upper molars, very difficult to retreat and very, very difficult to disinfect. You can still remove gutta percha, but you cannot disinfect the apical ramifications or the apical third or isthmus of the root canal when you retreat it. That is also again a risk factor. Pre-existing procedural errors. When you have done your primary root canal treatment, if there was some ledges, a perforation, transportation, instrument separation, all these things they have seen that these are the risk factors which can cause a failure of when you do a retreatment. Techniques used for root end preparation. Again, this is again a debatable topic. Which instrument to use the root end? Burrs, ultrasonics, lasers. Again, there are multiple lab studies. Again, all this, there is no enough clinical evidence at all. So you cannot say anything is better than one thing is better than other, because this is all based on lab studies where the design is very, very poor. Next thing is the material used for root canal filling. Okay, this is again one of the things, root end filling. It is not root canal, sorry, it is a root end filling. Again, here at least we have some good amount of evidence when compared to amalgam or zinc oxide or super EBA. Now the hydraulic calcium silicate cements are there. So majority of the hydraulic calcium silicate cements have shown promising results when they have placed in the periapical lesion for the long-term follow-up. Again, it is a case report. Age of the patient. Again, it is a common thing for healing. Elderly patient, healing is poor. Damage to buccal and lingual cortical plate. This is what I said, what is the drawback of surgery. When you do a surgery, amount of cortical plate present matters a lot for healing. So if there is a much amount of damage, then again the success will be less. Level of expertise. Already Dr. Krishna Prasad has spoken. There is nowadays in abroad, they are doing a lot of studies on level of expertise. Say they do a clinical trial, a student versus a specialist, and they will see compare the success after 1 or 2 years. And they have derived at the conclusion that expertise always matters a lot along with the magnification. Definitely magnification plays a lot of role for success. They have seen when a specialist has done in a pragmatic trial, that is when you do a trial in a private setup, not in an institution, under the magnification, the success is always better. So to end up, to summarize, okay, I'll show you some of the clinical scenarios. Okay, I think most of you have seen, but just to whatever I spoke now, just to show you some of the clinical scenarios where we do a non-surgical retreatment. Okay, this is a missed canal. Again, you can see here there's a big lesion. Okay, don't directly jump into surgery. try to find out, there might be some missed canal, go for a CBCT or anything and see for the extra canal, find the canal, disinfect properly, just obturate, wait and watch. The lesion will heal. Go for hydraulic calcium silicate cements, which has shown very, very promising results. Under obturated canal, again this is one of the common thing, just remove the old filling, re-disinfect, go for a again new filling and wait and watch. Over obturated canal, again here you can see these are all case reports what I am showing. There is a small gatapacha piece which is gone beyond. So they made a J hook in the file, they tried to retrieve, they were lucky the gatapacha could come out and they retreated and there was a healing. Now surgical retreatment. This is again one of a case, it is not published by my colleague Dr. Raj. Okay, he got a case, this, okay, it is a bayonet shaped canal. If you see obturation, it is not very bad, okay, it is not very good also, but there is a lesion, okay. But here, as I said, he could have waited and watched, but the patient wanted immediate results or early results. Patient couldn't come for recall. So that is why he had to go for a surgery and then he got a good bone fill and there was a healing. Again, one more case report, okay, in 2013 where a person used thermoplasticized gatapacha to fill the mesiobuccal canal. You can see how much of the gatapacha has gone beyond the apex, okay. So all these things, it has gone, actually it is in the sinus, maxillary sinus. So they had to do a surgical opening and they have to remove this gatapacha, okay. So this is again, these are all the classical indications for surgical retreatment. Instrument retrieval, you can see a small piece of instrument which has gone beyond the apex. I don't think any of the instrument kit which is existing now can remove this, as far as I know. I'm not much sure, but again they did a surgical intervention for this. They removed the surgical piece of the instrument and they could see a good healing of the periapical lesion. Management of calcified canal. This is again one of the common indication. Okay, you can see on this there is a very good article by James Gutman, where he said why you may have to retreat it when there is a calcified canal. Again, this is quite dilemmatous situation. We can see small apical 1 to 2 mm of the canal patent and coronal 1 to 2 mm of canal patent. In between, it is completely calcified. So here also again the same thing happened. There was a completely calcified canal, but here there was an adjacent tooth with an open apex and it was non-vital and there was a huge lesion. So they couldn't completely get the canal, so they had to do a periapical surgery. So these are all the indications, some of the indications for surgical versus non-surgical. But the only issue comes when there is an existing periapical lesion of long term where the patient is asymptomatic. What you need to do. So to conclude, every case of retreatment is different. If you see the case reports, etc., every case is different. There might be some errors or there might be some caution you need to take more when you do every case of your root canal treatment. Diagnosis and treatment planning has a very important role to play to determine the success. That is why I said whenever there is a lesion, don't be in a hurry to open up and do surgery. Wait and watch if the patient can be recalled. So diagnosis and treatment is very, very important. Non-surgical method of retreatment should always be the first choice, because if you see the literature, success rate of non-surgical is always better in a long run compared to success rate of surgical in a short term. Thank you.
Thank you, Dr. Vasudev Ballal, for that very precise presentation. Now, to just sum up this particular session, I think all the four speakers have given their point of view. I think I'll start with Krishna Prasad, who made it very simplistic, where he actually gave the factors which are responsible for failure of RCT, which was followed by Dr. Shanthipriya. I think I just like the way, because they say the colors, and it's very easy, the green, the orange, red, and the green zone. I think that is something which will stay with me. Because as a periodontist, it's very important because we still do not have an algorithm as whether to retain this tooth or to extract it. And that again was followed by our evergreen Dr. RAKSHITH, where I think he talked about the prognostic assessment as an implantologist. I think where he did stress that, that retaining a natural tooth is very important. That was very great coming from Dr. RAKSHITH. And then the last one was, of course, by Dr. Vasudev Ballal, in fact, I had a query for Dr. Krishna Prasad. I said, because most of the presenters, they talked about the residual scar. And I think my doubt is cleared by Dr. Vasudev Ballal with his evidence, where he said that with a 4-year follow-up, if the scar persists and there is no reduction in the size, fine. That is a good RCT. I think that was a wonderful presentation by all the 4 speakers. Now I think we'll open questions for the speakers. I think Dr. Karthik, you can start with I think since he's an endodontist, let him start with that, then I'll follow.
We have a few questions over here, and most of them are related to the presenters' presentations itself. So I'll start first with Dr. Vasudev Ballal. So we'll start with the last, so we can have some input from him. I think this has been answered in your presentation itself. So I can show, maybe ask you 2 questions. You can take any one. The one that I wanted to ask was, what should be the follow-up protocol in retreatment cases? I think you covered it fairly clearly in your presentation now. There's another question. Should we use culturing for more targeted deployment of disinfection strategies in retreatment cases? You mean to say
before obturation?
Yes, because in primary endodontic lesions, of course, we know that culturing is a very long drawn-out process, but in retreatment cases,
whether primary or retreatment, I think as such, we don't have any gadgets to evaluate chassis disinfection. When we do the study, that is when we do a microbiological study, that is one of the primary steps. Before you open the axis, you need to scrub the surroundings, rubber dam, tooth, etc. We need to take the culture. We need to detect whether there is a 0 microbial load. Then only we need to do a axis cavity. This is done when we do a study where we need to assess the microbial load in the root canal. When we do a study, I'm telling, when you do a research. But clinically, I don't think there is no gadget available where we can see a chair side disinfection. Only thing, we have to take the culture, and minimum is we have to do a gram staining, unless you have a lab next to your chair or in the same department. Otherwise, as such, there is no any gadgets.
Yeah, I think another dilemma, I think, since we have endodontists and we have 2 periodontists here, one of the dilemmas all of us have is an endoperio lesion. I think this is for Dr. Shanthipriya, and I think probably an endodontist can also butt in. What do you think is a success? What determines the success rate of an endoperio lesion? Especially with reference to the, the microbial flora, what they share. Does that make a difference? And finally, to Dr. Rakshith later, if you have a tooth with an endoperio lesion, will that really affect your outcome of your implant?
So endoperio, we have different types of lesions, endoperio lesions. If you have a combined lesion where perio involvement is there and endodontic involvement is there, and again it depends on how successful is endo treatment first and foremost, because every case of a combined lesion, first endodontic treatment has to be done for 2 reasons. One is if and when we do perio first and then later endo, what happens is once we open a flap and close it, pocket occludes. And when endodontist is doing the root canal, the periapical area, there can be reinfection. Through the canal, apex is open, so there can be bacteria which is entering into the periradicular area, and there is no way it can escape. So it gets pooled there, and there can be an abscess. Most of the times, patient will come with a huge abscess there. And second reason is, if we do perio first, the rule is that when we open a full thickness periodontal flap, wherever the defect is, bone defect, 1 millimeter of the normal bone has to be exposed. So if you are opening a flap around a tooth which has middle third to maybe one surface of the bone is exposed till the apical third, but rest of the tooth has up to middle third, and you deflect a flap, and that particular area where you have gone beyond the root apex and you are doing curating, so you disturb the periradicular vasculature, and that again causes severe pain. So in a combined lesion, always remember first endo treatment and then perio treatment. So coming to the success, again it depends at what stage are we treating the lesion. If it is endodontic lesion, definitely the success rate we have seen. Where the success rate comes down is with the perio involvement and how much is the perio involvement. By and large, if furcations are not involved and if it is only single defect, very good success we do see. But if there is a furcation involvement and also there is a bone loss extending at till the apex, then the success rate comes down. Long-term success. Maybe immediately you can treat it for a few years, but long-term success is not, there is not much evidence on that.
Yeah, I think, Dr. Rakshith, what I basically wanted is, if there's a residual periapical infection, like say, for example, it's a hopeless tooth, and do we have to take any precautions before you take an implant, place an implant in these cases?
Yes, madam. First thing is, we need to see whether the infection is acute or chronic. If it's an acute infection, I would always advise to extract, wait, and then go ahead with the implant placement. But if it's a chronic infection, and in this particular clinical scenario, depending on how much of buccal bone wall is present, if the buccal bone wall is good enough, then I would extract and place the implant at the same time. But the care what we need to take at that time is that we do a proper curettage and make sure that we have removed all the granulation tissue out. Flushing with betadine into that area and keeping it for about 5 minutes in that area is quite good. And then placing the implant, you will almost have 100% success without having any issue, especially if it's a chronic infection. Another care to be taken is when you have a chronic infection is I always ask the patient to go in with the oral prophylaxis at least 2 to 3 days prior. Start with antibiotics and then go ahead and then place the implant, extract and then place the implant. So I make sure that the inflammation is down, and then the final results are going to be quite good.
I would like to add one point here. So rightfully what Dr. Achit said was a chronic infection, but in case of aggressive periodontitis, it is always better to wait and watch. And recently there are a couple of articles wherein they proposed active treatment before you do the extraction. What it involves is that a patient is called periodically and just do a non-surgical therapy in terms of root planing, and also antibiotic or antimicrobial therapy is given before you extract the teeth. So once the inflammation comes down, an active infection is taken care of, then you extract the teeth, and then the granulation tissue, whatever protocol he said, we have to follow that. Sometimes we even use ultrasonic scalers to debride the entire socket area, and then we do place the implants. But in my experience, especially with aggressive periodontitis cases, in my study which I am about to publish, it has 48% of failure in case of aggressive periodontitis when I did the implants, and especially in the posteriors. So I think maybe it is better to wait for some time and have a staged implant only if it is aggressive form of periodontitis.
I do agree with madam to a certain extent that when there is aggressive periodontitis, we need to wait and then go ahead. But we are in a era where patients want everything fast. So we need to make the clinical decision depending on that particular patient. It is not always that aggressive periodontitis patients have problems. If you have to use the right implant for that particular clinical situation, an active implant in that particular clinical situation, and if you're made sure that you're debrided well, then you could get good success. The only region where you need to take care is whether we have to graft or not graft at the same time. That is extraction, implant placement and grafting at the same time, whether we have to do it or not. But if the buccal cortical plate thickness is good, then usually there's not much of a problem. Everything depends on the buccal cortical plate thickness.
I think we have one question over here. I'll put it through to Dr. Krishna Prasad. How do we decide when to obturate in retreatment cases?
In retreatment cases, see, when there is a failure, when you say the primary endodontic treatment is a failure, so whether it is a clinical or radiological. Radiographical means there is a already existing lesion is there, it is increasing in size, and along with that, clinical symptoms, pain, swelling, or discharge. So when it is there, we cannot do a single visit endodontics because we have to use, because there may be there is a biofilm is there. There is a lot of bacteria. Our Dr. Ballal has done a lot of studies regarding that, use of intracanal medicaments, etc. So we have to control first the microorganisms, then only we can obturate. Anything to add?
Yes, Dr. Sir has said it is always better to go for a intracanal medication. Okay, the choice is depending whether calcium hydroxide or triple antibiotic or anything, but it is better to disinfect and by giving an intracanal medicament rather than going for a direct obturation. It's always better, and success has been shown.
That would be the next question. The next question was, what is the role of intracanal medicaments in the success and failure of retreatment cases? And which would be the intracanal medicament of choice based on which circumstance?
So for your first question, intracanal medicament is a must when we go for a retreatment, and as Sir said, better don't obturate in one shot because we are re-obturating because there is a failure. And failure might be, I told you, majority of the time the failure is because of the improper disinfection. So you remove the guttapercha, you do the thorough disinfection using some activation of the irrigants. Again, it is a huge debatable topic, what gadget to use for activation. So you activate it and you go for an intracanal medicament at least for a minimum of 2 weeks. So the gold standard, what everybody uses is a calcium hydroxide. Again, if you see research, nanoforms of calcium hydroxide has shown to have a better result. Some of them go for chlorhexidine as a gel also as an intracanal medicament, thinking that, E. faecalis is a predominant organism, which that concept is no more valid. So till last few years back, they used to say Enterococcus faecalis is a prime organism for a root canal failure, but that is no more valid. There are so many other pathogens also, which could not be cultured. That is why they were not reported in the literature. But now, because of the beautiful higher techniques of culturing, they have found so many other microorganisms also responsible for the failure. So for E. faecalis, chlorhexidine is okay, quite effective, but not for all. So you can combine and chlorhexidine with the calcium hydroxide. That will be a very good option rather than going for alone calcium hydroxide or chlorhexidine.
And the periodontist, will the patient's underlying diabetic condition, would that affect your retreatment? Would you really take it into consideration?
When you say diabetic, ma'am, again, it is a common disorder. This is for poor healing. It is known fact.
You say, for example, you have a questionable teeth. You have a choice to retreat it or you want to extract it. So what would you go for? Would you take the chance in these patients of, again taking a call
again,
of,
when
retreatment?
you say retreatment, it depends whether there is a lesion, there is a periapical infection, there is a bone loss, or it is only a well-obturated root canal which has failed. So if it is a well-obturated root canal failed, definitely I will go for a retreatment. I will never think of any extraction or any surgical. No. The first way is always the conservative way. I go for a root canal treatment and I'll pay more attention for disinfection.
Okay.
When I do a root canal treatment. But if there is a lesion, okay, periapical lesion, again the same protocol what I said can be followed, but again it depends if the healing part, you have to wait and watch because diabetic is one of the confounding factor for healing. So it might retard healing, it might or may not. So we have to wait and watch, but definitely I will try to save the tooth.
Okay. It doesn't think we'll throw the questions open to the panelists. You have to add in something.
Yeah, it's not only the bacteria, it's the interaction of the bacteria, what is there, and the metabolites, what they produce, and the host response. That's what is the recent study with the metagenomic studies or metabolomic studies, what's coming up. Even with the extracted tooth for a biopsy or anything, so far it's not been addressed to this extent that the metabolites, what the human tissue produces, the tissue interaction with those, what is occurring, along with the bacterial byproducts or the bacterial toxins. That also causes some amount of destruction, which we may not be able to assess even with the CBCT or even with histology. We will not be able to decipher what exactly is happening at that molecular level. So it's not only just controlling microbial microbiome. It's their toxin and their interaction with the host. Tissue response also is very, very much important in this. So it's need not that one particular organism is going to cause something. As Sir said, it's not only E. fecalis we are just running behind it. It's an interaction of the E. fecalis toxins along with the other normal microbia, what is present, along with the bacteria, what is there in your attachment apparatus, which can have a lot of interaction, resulting in a failure. Clinically, we'll not be able to see just a pocket or something, but over a period of time, there will be root resorption or something, which we'll say, okay, probably this could have happened. Now with these metagenomic studies or metabolomics, we can really decipher what exactly is happening. Probably these are things we have to see in the future.
Just to add on, this host immune response is very well documented in periodontology, unlike endo. They are way ahead of us in every aspect of research when you see. So for this host immune response, especially for the cytokines production and all, they already are coming up with a target which acts against cytokines. In endo, we have not tried all those, but in perio, it has been already started. So where they don't target the microbe as such, they target the microbial product, cytokines, interleukins, TNF, etc.
I think we can open the questions to the audience. Does anybody in the audience want to ask anything from the panelists? Yeah. Can a mic be please?
After the question, I sum up? Yes. Good evening. Thank you everyone for the enlightening session. I had a question for Vasu sir. So what are your thoughts on partial retreatment, especially in case of posteriors?
Partial retreatment, I didn't get you.
So as in multi-rooted teeth, when we only choose to...
In multi-rooted canals?
Yes, and in teeth also. We only choose to retreat one canal or probably the one that...
See, again, it depends, like if there is this usually we do when we go for an endoperio lesion. When there is an endoperio lesion, when there is a bony defect around one particular root, there is a poor prognosis for that particular root, we usually tend to extract that to the root resection or anything like that we do. But if it is a primary endo which is reinfected, even though you see radiolucency only in one root, there is something called as a rebound phenomena. Okay, there can be the other root also can be infected. So it is not a good thought to only clean and shape the tooth where you can see the lesion. It's better you always clean the other canals also.
Thank you, sir.
Just 1 second. There is a clear-cut indication given why you need to retreat the other root which has already been treated. Of course, these are all done quite before this advent of CBCT. Wherein Quist et al. Have given a clear-cut criteria in American Association of Endodontic publication. Even a tooth which is exposed to bacteria, it need not be saliva from the other canal, so-called infected or not infected. The bacterial toxins are able to penetrate into the other canal along the gutta-percha or lateral ramifications or through the sealer space or the space between the sealer and the root canal wall, even though it is well prepared, within a matter of 48 to 72 hours. So the question doesn't arise whether you don't want to treat that one root or you want to treat it. So should be retreated. In fact, if it is exposed to oral cavity, definitely all root canals should be retreated before whether you're going for a non-surgical or a surgical retreatment.
And yes, one more thing is that in my clinical experience, most of the retreatment cases, what I have treated was missed canal. I found many cases. So canal, if we miss one canal, like say premolars, especially the premolars, mandibular premolars, like what I have faced in the northeastern region is with the Mongoloid peoples, they have a very different type of the canal system. So many times the accessory canals are very much common. So people think that yes, it is a single root canal, so they will deal only the one canal only. But later on, maybe say after 5-6 months or even 1 year later, they will come with a complaint of pain and the radiolucency, this and that. Then when we open it, then immediately next to that main canal, there is always lateral canals are present. So missing the canal is one very important. So that is why I don't think that treating one canal or two canal, leaving one or two, that doesn't arise.
So, thank you for the wonderful sessions. Ma'am, talking of missed canals, I had a case where only one tooth was severely discolored in the mandibular central incisor, and it was symptomatic also. So when I went for retreatment, there were 2 canals. One was missed, but the other in IOPA showed periapical without symptom. The other teeth were TOP negative. So in one I found 2 canals. So is there an incidence that we have to go for any kind of intervention for the remaining ones also, in spite of it being asymptomatic at that stage, when we have figured out that one developed a symptom after some time and we found a missed canal in one of those 4 mandibular teeth?
Actually, whatever is the situation, so whatever the obturation was there may not be the perfect, may not be 100% sure. So for me, I always do the retreatment, even the main canal also, along with the accessory one.
Okay. No, ma'am, I'm talking about the other teeth.
Other teeth?
Ma'am, there were 4 mandibular incisors, all were obturated. One developed symptom, and I found this missed canal in only one. And there were periapical lesions, which were like, there was no symptom, but periapical lesions were there in all 4. So do we prophylactically open up to find any missed canal even in the others, or should we only treat when the symptoms
not exactly. It is not required, but we have to wait and watch. Treat the one canal, the opening tooth, and the rest 3 we have already filled obturated properly. In those conditions, wait and watch is the better option.
If it's possible to do follow-up, as sir said, 4 years, yes, it's a good thing.
And one more thing is that in my clinical, this one scenario, what I have seen is that most of the, even if there was a big radiolucency in the periapical area, and if we have done the obturation properly and the core below and everything done perfectly properly, then all the radiolucency, they healed up, even after 2 years of period of time. So what the doctor was telling that after 4 years of time, that the radiolucency still remains or enlarged or is not reducing, then I think retreatment we should go off. Because in those conditions, again, we are just allowing the tooth itself again growing making the lesion larger. So instead of waiting for that, I think better we go proceed for the retreatment.
Thank you, ma'am.
Good afternoon. I had a question for Vasu sir. Sir, what will be the role of antibiotics in retreatment?
As an intracanal medicament?
No, role of antibiotics, systemic antibiotics
Systemic
during
as such, we
retreatment.
don't advise.
Okay.
I think if there are no further questions, we'll ask the senior most endodontist or conservative person, Dr. Wadhwani, to please summarize the whole session.
Yeah. Thank you very much. It was very, very interesting and very challenging topic today. I thought when the session started, I thought there will be very heated argument because endodontists want to save the teeth and implantologists want to extract the teeth and put an implant. But Dr. Rakshith, thank you very much. Being a prosthodontist, you recommended that retreatment, all possible treatment to be tried and then implant to be decided. I'm told his wife is an endodontist, so he has to be better at home. So no hesitation. But I feel this is the right approach, whether an endodontist or a prosthodontist or an oral surgeon, the decision making should be done very judiciously. Whether to go for an implant or whether to go for an endodontic treatment. I always say endodontic treatment is a blind treatment because everything is closed. Coronal portion we open and we go up to the apex. But now with the advancement in technology and investigating method, we are no more blind. So we can see missing canal, crack, pathology on the lingual aspect or on the buccal aspect, everywhere we can see and have a proper diagnosis with the CVCT. CVCT has been a boon to the endodontist. Boon to all specialty, but special. That's what it is, to all specialty, but especially to the endodontist, because endodontic treatment is absolutely a blind treatment. Only your tactile sensation which matters the most. Your skill matters the most. You may have everything, ultrasonic, this, that. But unless and until you have a proficiency, nothing is going to work. So all four speakers, Dr. Ballal, Dr. RAKSHITH, Dr. Prasad, and Dr. Reddy, they spoke with very clarity and to the point, and which was very, I think, understandable by the postgraduates. And this is the beauty of any presentation, when everybody can understand what is being told to them. Thank you very much for all of you, and thank you, Dr. Karthik and Dr. ASHITHA. Wonderful, wonderful support and wonderful session. Thank you very much. And
Thank you,
Dr.
ma'am.
GOWRISH and Dr.
Thank you, ma'am. I now request Dr. Rupa Nadik to give away the mementos to the panelists, resource person, and the moderators. Shanthipriya Reddy. Dr. VASUDEV BALLAL. Dr. Rakshith Hegde. One second. Dr. Krishna Prasad. The expert panelists, Dr. PREMALATA.
Senior madam, Wadhwani madam.
Dr. Hang me now. No. Dr. GOWRISH.